Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Teledyne Pulse. Shane, this is part 4 of our series on digital strategies. Part 4 already.
Yes, Andy, part 4. It's hard to believe we're at part 4.
I know it.
Already with this process that we've been working on in terms of strategy for hospitals. And the place we're going to start today is talking about system metrics and challenges. And this is just another phase, if you will, of trying to help hospitals build clarity around how virtual programs can really make a difference for their hospitals and health systems. And this is an area that oftentimes is overlooked when it comes to how can these solutions really make a difference. When people think of telemedicine, they really think of a physician coming on a screen of some sort and seeing a patient and offering some sort of diagnosis or additional supportive diagnosis or whatever. In this instance, we're going to shift gears a little bit. We're going to talk about system metrics and challenges that tend to aggravate hospitals and CFOs and quality people for, in some cases, for months, years. And really have struggled internally to fix these things. And so we're going to talk about a few of those today.
Okay.
And I think we'll start off with more of the critical access hospital side of the equation, which is maybe a little less relevant in this section as opposed to the PPS side. And then the latter half of this conversation, we'll get into more of the prospective payment hospitals and benefits for them. But I think we'll start with the critical access side and focusing more on the regulatory environment and hospital-acquired infections. And from a regulation perspective, we tend to see a lot of issues, if you will, of meeting the regulations as it relates to antimicrobial stewardship programs or things along that line. And so ensuring that your programs that you're offering not only deliver value in terms of the patient proposition and in terms of the hospital proposition financially, but also meets or exceeds the regulatory components or the conditions of participation put out by the government. So most stewardship programs, I shouldn't say that, it's not most, but we have come across programs that don't do that. They don't meet those things, and we've come across several internal programs that don't meet those requirements. And so it's important as you're considering a partner on that front to ensure that you will meet or exceed those requirements. And so I think that's an important piece as you look at a regulatory component. Furthermore, if you're looking at not necessarily a regulatory component, but maybe a certification or an accreditation of some sort.
Stroke center.
So stroke center. Do you have the wherewithal internally to manage the stroke center certification process?
Right.
Or do you have the services in place to meet those requirements? Do you have the policies, protocols, et cetera, that are demanded by those types of centers? So there's a lot of things that can be there. We can offer a lot of assistance around those components to help with those certifications and or accreditations. And so that's an important piece, I think, as you're looking at partners for your virtual strategy. And, whether it's trauma center designation or various nursing center designations, Leapfrog, for example, we'll talk about that. That's not really a critical access issue. But there's a lot of factors that virtual programs can really make a big difference in when you're trying to achieve those programs. Because oftentimes when I'm talking with CEOs or CNOs or CMOs and they're considering or contemplating an accreditation or certification of some sort, we don't have that physician resource, or even if we did, we don't have really anybody in-house that can really put the effort into putting that together for us.
Right.
And, we're really here to help hospitals achieve those things because we've seen some significant improvements in patient care locally.
Oh, absolutely.
And subsequently, retention of those patients locally. So in the end, we're providing better care for that community, keeping more patients in that community and overall healthier community. So they can make a big difference on all those fronts. And so I'm not hitting them all, but there are several areas as we talk with hospitals. I'm always interested in, what are your goals? Where would you like to be?
Yeah.
And there's been several occasions where they go, well, you probably can't handle this or do this, but we have this as a major issue. Well, I'm all ears. What is it? Maybe we have something that can help. So it's always great to have those conversations. Quality scores and satisfaction scores are another area that most people aren't going, gosh, could a virtual program impact these areas? And or the flip side of that conversation is our quality scores, our satisfaction scores are great. If we did deploy virtual programs, is that going to implode those scores?
That's a question.
It is. We do get that, right? And by the way, I don't blame them.
Right.
I mean, if their scores are perfect or
really good,
the last thing you want to do is bring in a virtual program that's going to implode your scores. So
right.
we don't want to do that. And so it's an important piece to consider. But we have seen in both instances, both on the quality side and on the patient satisfaction, an improvement in the overall satisfaction scores. And interestingly enough, and this gets back to our first episode, which, by the way, if you haven't listened to episodes 1 and 2 and 3, please do so, because there's some great content in there. But I would say that from a community perception perspective, you're only graded on the patients you're taking care of in the facility.
We talked exactly about that in the first episode of this series.
Right. And that gets back to community perception, right? So the question is, if you're going to start taking care of a different subset of patients or a higher case mix than what you had been doing previously, I would shift that conversation with the administration to, can we maintain those same quality scores or potentially better, even though you're taking care of more and sicker patients?
Exactly.
And we've proven out we can do that.
Yeah.
And so those are the things that, as you talk about virtual programs and try to understand the impact of these programs, what that looks like for the organization. And I would say that it really comes down to the partner that you're ultimately going to work with on these fronts, because they can quickly implode those scores if it's done poorly, for sure.
Oh, absolutely. And we've cleaned up some wreckage.
We have. And by the way, I don't wish that on anyone. That's not a fun.
Absolutely
that's not a fun process to go through. In terms of readmissions, we typically don't see a lot of readmission issues in the critical access markets, just because they're maybe not aware of them quite as much. But little things like adding, there's data, peer-reviewed data, in terms of having a pulmonologist, for example, involved on a COPD inpatient stay and a direct impact on readmissions.
Yeah.
So it's things along that line that we can seamlessly integrate into the programs, that just by having a pulmonologist available to see that patient improves dramatically the likelihood they're going to stay out of the hospital post-discharge.
Yep.
And in many instances, it may be a follow-up visit with a pulmonologist in the outpatient center in the virtual outpatient pulmonary clinic.
Right.
So there's a lot of those factors that really drive home the need for a comprehensive evaluation of what you're trying to accomplish. And can virtual program help? And boy, of course, I may be biased.
Maybe a little.
I will tell you that a lot of times they can.
Yeah.
A lot of times they can.
Yeah.
So I think we'll shift gears, and certainly the hospital-acquired infections, in some cases in the busier places, may be applicable in the critical access markets. But in a lot of instances, again, the volumes are low enough that maybe they're not as tuned into that as some of the bigger facilities. But if you are having issues with it, absolutely, we have addressed those issues in dozens and dozens of hospitals and had some significant wins on HAI situations, to the tune of, as we switch gears here now to more of the PPS side of the equation, when it comes to things like CLABSI or CODIs or even C. difficile issues, which those three we've had significant wins and across all three of those.
We have.
And I would say that when people start to think of those infections, the first thing people gravitates to is infection control, which is an implicating factor in many instances.
Of course.
But, if your initial run of the infection control adjustments, changes, modifications, whatever you want to call them, is failing, or you're still not getting the results you need, you probably need to look a little bit further into the puzzle.
Yeah.
And oftentimes things like the comprehensive antimicrobial stewardship program can make a huge difference on that front.
Yeah. Change in drug, change in duration, change in delivery.
It can, and in certain instances, I'll give you just a couple quick examples. So if you look at CODI or central line infections, in one institution that was being penalized several $100,000 for CAUTI, for central line infections, and they were, again, heavy focus on infection control and donning doffing procedures, cleaning procedures, timely, blah, it just went on and on and on, and really not getting anywhere. Well, what we found was a gross ordering of central line placement and ordering long-term antimicrobial therapy that wasn't needed at the end of the day. And so we blocked in the first, I want to say it was in the first 90 days, it was like 16 central line insertions. And by the way, if you don't have a central line place, guess what? You can't get an infection. So it really is. But I tell you really got to have ID involved in that process, working closely with pharmacy, and it's a great project and program, and so phenomenal results there. A couple of others on the urinalysis components and helping an organization reprofile their urinalysis process in terms of the triggers to order a UA, the triggers to then culture a UA. Had some dramatic wins on that front. C. difficile was another issue we had, and I had a call from a CMO of a large, it was a 200-bed facility. I don't recall the state off the top of my head, but in that scenario, they were wrestling with C. diff and had fought it for 3 years of very high C. diff rates, and through infection control, it was an infection control issue. And they went on and on and on with infection control changes, adaptations, and they really weren't having any progress. Well, when we got involved with that program, what we found was a gross overutilization of vancomycin, and way overutilization of vancomycin to the point of therapy days way in excess of where they should be.
Yep.
So, which in many cases is a absolute risk factor for developing C. difficile. Yep. So, we not only that, we profiled that down to the physicians involved in that process, and through infectious disease strategies and the infectious disease physicians being able to talk with the med staff in general and offer education to the med staff in general. Again, these are fragile situations, right?
Absolutely.
So,
you've got some egos here, and
Well, I mean, you don't run into any egos out there, but there are a few that get a little defensive if you start inquiring as to why they may be ordering a particular drug for a certain duration or a certain dose. So, but a dramatic success, and that program actually went on to win an award at the National Infectious Disease Society of America conference. So they do work. So, but a lot of people, when they think about things like central line infections or Foley infections or urinary tract infections or C. difficile issues or any other hospital-acquired condition for that matter, again, most people think of infection control, but there's a lot of other strategies you can deploy that really make a difference.
Yeah. Yep.
So I think the next place I'd like to go with the PPS side that's a little people don't think about virtual strategies is in the throughput. And so I in fact, just had this conversation last week with the CEO and administration team, and listening to their challenges. And one of the challenges they had, or I just posed a question as part of a list of questions, and one of the questions was, do you have problems getting folks out of your emergency department? And they said, well, yeah, we have people waiting in line and waiting. And so the question, you can go down the road of about 12 different angles on what's the root cause of that. And this has been studied for a long, long time, right?
Yep.
And there's all kinds of theories out there by dozens of authors, and it's been published and peer-reviewed, and all down the line, right, of all the challenges that could be bottlenecking your
ED throughput.
ED throughput.
Yeah.
And it could be on down the line. So in this conversation as well, our ICU is full, and we have a lot of people waiting down the ER. We got to hold them there because the ICU is still full. In some cases, we can't get them out of the ICU because our step down's full. And so as you start thinking about, well, it's not just throughput out of the ED. You got throughput issues throughout the whole chain, right?
Right.
And this generally is not earth-shattering to most. It's like, well, yeah, beds are full, so we can't get them out. Well, the question is why are the beds full? And I pose a simple question, well, if we reduce your length of stay in the ICU by 0.2 of a day, that'd probably make a difference, wouldn't it? I mean, if the patient's out the door 6 hours faster or 4 hours faster or 8 hours faster, that'd make a difference. Well, yeah, Shane, you get them out of the ICU fast, but our step down's full. Okay, well, why are they still there in the step down unit?
Right.
So let's have the same questions for the step down unit. Well, Shane, they can't get out of step down unit because then let's go there. Why can't we go here? And so it's a downstream channeling of what are the implicating factors of throughput. And as you drill down on that, there's a lot of factors that are involved that virtual program and virtual strategy can make a huge difference. And things like, simply, most cases, you're going to find a bottleneck in discharge process.
Yep.
Discharge education, med reconciliation, discharge planning, whatever you want to call it, is an issue. And a lot of times the nurses are so busy or too busy, and it's very challenging for them.
The hospitalist says at 8 o'clock in the morning, the patient could go home, but maybe it's going to be 1 o'clock this afternoon before all that stuff gets done.
Right. Or 2 or 3 or 4. Because that same nurse is supposed to do the discharge now has to do a high-end admission that's coming in, that's being transferred in, and all of a sudden that kind of throws everything into a tailspin.
Yep.
And then if they do get the discharge done, it's oftentimes not terribly effective, which puts risk for readmissions on the table. So as you look at that and you go, well, maybe can we leverage a virtual nursing program that actually can help with that? And my answer is yes, absolutely. In the ICU, through an ID strategy, can we reduce lengths of stay by appropriate antimicrobial components moving into that program? So can we de-escalate faster? Can we move them from IV status to PO faster?
Yep.
Can we do several things different? Pulmonary involvement, for example, if they're on ventilators or pending ventilators, or maybe we could avoid putting them on a ventilator altogether by doing X, Y, and Z.
Maybe a BiPAP.
Because that, anytime you throw somebody on a vent, the odds of them getting off right away are limited.
Yep.
So is there ways we can avoid that to begin with and turn them around faster so they're not clogging up the ICU? So there's all kinds of different angles we can look at in talking with hospitals and figuring out what would make the most sense based on your current predicament.
Yep.
So that's a big factor. And a lot of people, when they think throughput, don't think virtual or telemedicine applications. And there's a lot of different areas and I only went through a couple or hit on a couple areas that could be bottlenecking in terms of your throughput. There's even ED and virtual ED triaging mechanisms that can be funneled through ERs to make a big difference, depending on where the bottleneck is. If your ICU is empty and you still have bottlenecks in the ER, so there may be true throughput issues just coming out of the ED, and there's virtual things you can do with that to address them. So it's looking at complex problems. And one of the things I think I always encourage administrations to do is think, is there a virtual answer here not the virtual answer, but is there is there a virtual program or solution that could make a difference for us due to this particular need or challenge? So there's a lot of options there on that front. In terms of ICU and case mix and just overall physician satisfaction, and we talked a little bit about this previously in a couple of the other phases, but certainly if you're looking to increase your ICU census, these are powerful programs to put in place to help support and augment that. Yeah. And as a general rule, if you're looking to increase your case mix overall, again, sometimes the buck stops with the hospitalist program, and oftentimes it does, and rightfully so in most instances. I would challenge them to ask a follow-up question, though, because typically you're going to have variability across your hospitalist team on who's comfortable with critical care or ICU care versus not. Right. And those that love to do it, you have those that kind of like to do it, which is pretty rare breed. Most of the time, it's either you love doing it or you hate it. It's one of the two, usually. And you have some that are kind of in the middle, but most are either side of the spectrum. And then the question is, well, if that's the case, maybe you have one out of your 5-person team or 2 out of your 10-person team or 5 out of your 20-person team that enjoys doing that. What happens the other 15 folks are on? Right. And can we augment our ICU to be able to access specialists to help us out on that? And the other piece I'll touch on as it relates to, I mentioned credentialing and certifications, which would, not credentialing, but more of certification process. Yeah.
Stroke center, trauma center.
Yeah. And, for the PPS side, if we've helped hospitals, for example, that are standard certified stroke center to comprehensive, and hardwiring endovascular strategies. In fact, we've even assisted with employing endovascular physicians as part of the program and help design the program and be the medical director for that program, and then a comprehensive service line management piece of that program.
Right.
And achieving certain certifications. And so there's a lot of options people maybe don't think about, because oftentimes in talking with folks, we have the resources here in terms of facilities to be a strong comprehensive center, but we don't have endovascular.
Right.
Or we tried it once and it failed. And I would pose the question, well, what if you had a partner that could help on all those fronts and help build the program, help achieve certification, help direct the program for that matter, albeit a partner and a virtual one at that, but it is proven to be very successful across multiple hospitals. So lots of different options on that front. When it comes to, I'll shift gears here again a little bit towards microbiology and how hospitals view their micro lab, and of course people in podcast land are going, what are you talking about microbiology for the virtual program? But it's worth mentioning that we have hospitals that come to us with challenges on PCR testing, for example, to name one.
Yes.
And holy moly, we have this biofire unit, and our physicians are ordering on these outpatient respiratory panels, and they're going to leverage PCR to speed this process up. Well, the problem with that is, those tests are about $120 a piece or thereabouts, and the reimbursements is next to nothing on those tests, particularly on the outpatient side. So,
right.
And it's built into the cost on the inpatient side. So you really do have to police that, if you will, in terms of what's going on there. And in this particular hospital that we were working with, now we were managing a lot of acute care ID stuff, but this problem was brought to us by the quality officer who had challenges with this outpatient ordering of PCR. And she actually just happened to mention it in passing. We were talking about a different quality metric we were working on, and she happened to bring it up in conversation. She go, God, we can figure that out. So let's get a call together with our ID team, and let's profile what's going on here. And it was a quick meeting, and we did a quick presentation to the med staff. We helped draft a letter to the med staff how that service was no longer going to be available on the outpatient side, and then they were fine with it. When the ID physician presents the information and the data to the med staff, it carries a lot of weight.
Yeah.
And it's very helpful for some of these large organizations to have that access to those folks to be able to help with that.
Yep.
So we made a big difference there. We've helped hospitals on developing biofire rapid response teams, almost like a typical RRT. The only difference is it's a sepsis-related protocol policy that actually could help with early sepsis identification and early antibiotic strategy and leveraging biofire correctly. And we've had hospitals that had biofire and use it very well. We've had some that have biofire and use it very poorly. We've had hospitals that had biofire and didn't know they had biofire. I mean, it's all over the map.
Yeah.
So there's a lot of different questions related to PCR testing and other types of systems that can really help identify best case practices and best practices on how to do certain things with those programs. And in both cases, save those hospitals hundreds of thousands of dollars that they were spending that just didn't need to be spent. So in today's day and age, those are big wins for those types of programs. So the point of this discussion today, Andy, was really to kind of go through, just to give some folks a little bit different angle on what things you may consider as part of a virtual program. Is there an option that might be able to help with those particular issues?
Yep, for sure. What about quality scores, leapfrog, those kinds of things?
Well, in the leapfrog, we've helped hospitals on that front too. It just depends. There's a lot of different variables with leapfrog. Depends on, I won't go through all those now, but it really depends where your issue is and the challenges. So I think if you have leapfrog, or you're interested in obtaining leapfrog or improving your leapfrog scores, the most common call or question I get around leapfrog from a CEO or CMO is, hey, Shane, I our leapfrogs were an F, we're a C minus. We'd like to be an A at this level. What do we? Is there anything you can think of that would help us get to that level based on a solution that you can help us work through? So, and that's just really an analysis of the back end, what's going on, and what's contributing to that score.
Yeah.
In some instances, it may be just a lack of pulmonary critical care coverage.
Yep.
Could very well be an issue, and we can. Just by adding that service alone is automatically going to bump your score.
Yeah.
So stuff like that.
And the input from ID, for hospital-acquired infections, things like that.
Yeah. There's a lot of, there's leapfrog's relatively broad in terms of the various things it's covering. So that's really almost a whole separate discussion. But the bottom line is, again, virtual programs oftentimes aren't thought about when it comes to improving things like leapfrog or quality scores.
Yep.
And I would say from a quality score perspective, very similar to the critical access discussion here a few minutes ago.
Yep.
is very similar that we can absolutely help with quality scores and either maintain if they're great or enhance if they're not so great.
Yeah.
I thought that was good discussion.
Yep.
And again, certainly in podcast land out there, if you have suggestions for a podcast, certainly let us know.
Yep.
And
send us a note, pulse@teledynehealth.com.
And certainly rate the podcast and give us feedback. If you can offer feedback, that'd be spectacular. And even if it is, hey, can you guys go off the airwaves? Well, perfect. I think that'll wrap this one up.
I think that will wrap this one up. Okay.
Perfect. We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.